Hi everyone, it's Cindy. Welcome to the Opthal part of the GP revision series. Before we begin, I just wanted to emphasize to please not get bogged down on ophthalmology in 4C. I think it's still really important to know the main conditions in ophthalmology, which are mostly the red flags, and their management plan is usually referral to Opthal or ED with an Opthal department in the hospital. The main things that you still really want to focus on at the end of the year for your exams are your 3B type conditions and their GP-based management. So please don't spend too much time on ophthalmology. Put all your effort into the main conditions that you really actually want to be focusing on. But let's get started. This is a special thanks to RACGP who have been sponsoring us and supporting GPSN. If you have any questions regarding what it's like to be a GP or the pathways, definitely shoot them an email, which is at the bottom of the slide there. The team are very lovely and they're very supportive. So the format of the revision lecture is to firstly cover the history and examination approach. We'll then go through the main differentials, which I think will be relevant for your end of year exam. Some of the differentials that aren't relevant, we'll speed through them. And finally, we'll include questions at the end. They won't be recorded, but they'll be made available for you to go through in your own time. So let's first take a look at the history. The main points to consider in your Opthal history is the timeline or the onset of the presenting complaint, as well as the location. For example, is it only affecting one eye, both eyes, and if it's a foreign body, is it located on the cornea, over the iris, pupil, sclera, as this will guide how you manage the removal. So questions like these will be important to consider and to think about at the back of your mind. And of course, you also need to keep in mind your systems review questions listed below here. As you are going through the history, both in a GP and ED setting, essentially you want to make sure that you rule out any red flag differentials. So it's important to keep these differentials, which will be on the next slide, always at the back of your mind. So these are your differentials, and we'll cover a majority of these that are most relevant to your exam at the end of the year. So as per usual with any examination, you start off with a general examination. You can get a lot of information by initially observing the patient. For example, does the eye look intact? Are there any particular injuries? Is the eye red or white? And is the redness, and how is the redness spread apart? Is it localized, diffuse, or are there any limbal or perilimbal injections? Other things to consider whether or not the condition is unilateral or bilateral, and this could either be redness in both eyes or one eye only, or if the loss of vision, for example, is only in one eye or both eyes. Other things to consider are such as cellulitis or swelling around or underneath the eye, and any cranial nerve palsies, so in and out palsies, things like that. And importantly, you can also really gauge whether or not the patient looks well or unwell. And that aspect, the unwell or unwell part, is quite important to consider. Visual acuity is tested using the best corrected vision, and if the vision is suboptimal, we generally use a pinhole to determine whether it's a refractive or non-refractive condition. Depending on what you're working up, colour vision isn't always the most important aspect of the exam to perform. Instead, you should really focus your exam on cranial nerves. So, for example, by testing relevant reflexes, including the pupillary light reflex, both direct and concentric, accommodation and corneal reflex, blind spots, visual fields, particularly if there is visual loss or change, and the red eye reflex. I have included the Amsler grid on the slide, but it's not usually a test done in the GP setting. Rather, it's a tool given to patients, particularly those with macular degeneration, to use every now and then to determine whether or not there are any changes to their vision. Patients usually will have the grid on the fridge so that they can test their vision whenever they're going to the fridge. I've popped an additional resource in the comments. It's quite specific because it's more tailored towards GPs and like relevant ophthalmological conditions and examinations. I forgot to mention before in the previous slide, but with eye movements, while you observe for nystagmus, you should always ask the patient if they notice any double vision or pain, because most of the times they won't offer that information up to you. So moving on with the eye exam, firstly, it's important to always consider where you actually are. For example, are you at the GP clinic or are you in the ED? as this will limit or determine what you can use to examine the eye. The main tools or equipment you should familiarize yourself with is the ophthalmoscope, which provides a better view of the posterior eye than the anterior eye. So focusing on the external components of the eye first, you should examine the eyelid, including everting the eyelid for trauma in foreign bodies. This is excluding penetrating eye injuries. So whenever there is a penetrating eye injury, never evert the eyes. So to evert the eyes, I just got this off of RCH, just because the explanation is quite clear there, and it's much harder to describe how to evert the eye than to show. So firstly, ask the patient to look down and gently pull the upper eyelid down and away from the eye itself or your globe using the eyelashes. You can generally use the cotton buds to do the exact same thing by putting it on the midpoint of your eyelid or the patient's eyelid, and then give a little bit of pressure downwards and then move the eyelid up over the cotton bud. And then after this, you can either keep the cotton bud there or slide the cotton bud towards the side, or use your fingers to hold the eyelid up. You should also assess for pupillary defects such as pupil shape and size, symmetry with the other eye, and for relative afferent pupillary defect. With the cornea, other than the reflex, you should observe to see if there is any cloudiness or visible hypopion. These pupillary assessments should be performed before fluorescein staining, which is helpful. So the staining is helpful to visualize ulcers, full thickness defects or tears, and conjunctival abrasions. While you use the fluorescein stain, you should look for vertically linear corneal abrasions, as these generally suggest a foreign body under the eyelid. Now, the fluorescein staining really depends on whether or not your GP clinic has fluorescein dye. If they don't and you do need to use it, depending on the urgency, either send them and refer them to an ophthalmologist or to an optometrist. So with the anterior chamber or the anterior eye, the slit lamp is the best tool to observe this, but it's not a common equipment you'll see in GP land. However, it's really great to provide much greater magnification and illumination of the anterior eye and its structures, such as the cornea, the sclera, the iris, and pupil. It can also provide a view of the fundus or the posterior eye, but the ophthalmoscope is quite good at doing that already. The slit lamp also allows you to see what the depth of the foreign body is, and essentially that will guide how deep or how much pressure you need to use on either the bevel or the needle or the burr to remove the foreign body, which we'll go into a bit later. But for the posterior eye, the main things you want to consider is the fundus. And so the areas of the fundus include the optic disc, the fovea, the macula, and the vessels itself. So are the vessels engorged? Is the cupping at the right ratio? So the cupping of the optic disc at the right ratio? Are the optic discs on both eyes edematous, which would suggest papilledema? And other relevant findings that are more specific to certain conditions, such as cherry wool spots. So those are the things that can be observed. Let's start going through the differentials. First up is red eye. These will be split into painful and painless red eye differentials, and we'll cover the causes of a painful red eye first. So acute angle closure glaucoma is one of the most important conditions to take away from ophthalmology. It's a medical emergency and occurs most commonly through a pupillary block, leading to retinal ganglion cell death. Pupillary block occurs when the flow of aqueous humor from the posterior chamber to the anterior chamber in the trabecular meshwork is obstructed by a functional block between the pupillary portion of the iris and the lens. This can be due to a shallow anterior chamber, thickened lens, dilated pupils, which lead to the apposition of the iris and lens as the aqueous pushes the iris forward, causing the iris to push against the trabecular meshwork and thus leading to obstructed outflow. This will ultimately lead to a sudden increase in intraocular pressure. In acute angle closure glaucoma, the intraocular pressure is typically greater than 40, whereas the normal intraocular pressure is less than 21. The sudden increase in intraocular pressure causes axonal damage, which leads to visual field defects and loss of vision or photophobia. The patient history will generally provide several clues to the diagnosis of this condition. Typically, patients with this condition are over 50 years of age, more often women than men, long-sighted, and or with a family history of angle closure glaucoma. On presentation, the eye will be injected, the cornea can appear odematous or hazy, and the pupil will often be in a mid-dilated position. The patient will often have noticed a significant and rapid decrease in the visual acuity, and this condition is almost always monocular. It is often associated with nausea and vomiting, and so those are some of the questions that you really should be asking patients if they come in with red eye and pain in the eye. So some of the buzzwords I've highlighted, or the buzzy things to remember, are highlighted in red. So with the investigations of acute angle closure glaucoma, you're probably less inclined to perform the investigations in a GP setting given the resources and the severity of the condition itself. If you are quite certain that this is AACG, then realistically you should really just be sending the patient off for an urgent ophthalmology opthal referral. But in the case of revision, essentially you would test for intraocular pressure, and typically speaking, the intraocular pressure in patients with glaucoma, like I mentioned before, is over or greater than 40. If you were to do a fundoscopic examination of the eye, a patient with glaucoma should have a cup to disc ratio of 0.6 or greater, where a normal cup to disc ratio is 3. So what I mean by the cup to disc ratio is essentially on your fundoscopic examination, I'm going to hope that this laser works, but you've got your optic disc here, which is this palish yellow or more pale, I guess, circle, and you've got your cup. And essentially you would want to measure the ratio of the cup, so this small thing, to the optic disc, like you would here. And if the ratio of the cup to disc is less than 3, that's normal, but if it's greater, then this should start ringing alarm bells. A gonioscopic examination is a gold standard to assess the angle between the iris and the cornea to determine the extent of the closure. It doesn't necessarily diagnose acute angle closure glaucoma, and it's a subacute type of investigation and really shouldn't be considered when you have determined that this patient has acute angle closure glaucoma. The management of AACG can be simplified as the STAMP acronym. So what this stands for is supine, timolol, A for azeto, oh my god, I'm not going to pronounce that, but that one, mannitol, pilocarpine, and dexamethasone. The most important thing, like I mentioned previously, that you must consider and must do is an urgent opthal referral before you before you move on to the rest of the management, which involves lying the patient supine to avoid dilating the pupil, giving the patient analgesia and antiemetics as they'll most commonly have nausea and vomiting and be in pain. The medical management is really to control the intraocular pressure and the inflammation involved in AACG. The definitive management in this case is surgical, and it's a bilateral laser iridectomy, as both eyes are at risk of glaucoma. Additionally, if you are in a GP setting that is quite far away from opthal care, for example, in a rural setting, and you do have the medical management resources readily available, then you should consider giving it then. But things like IV therapy is unlikely to be an unlikely resource. So considering topical timolol or pilocarpine as the patient waits for the ambulance. Corneal abrasions are defects in the corneal epithelium, often caused by trauma, such as foreign body, particularly in the upper eyelid, contact lenses, or mechanical trauma, such as scratching, or mascara brushes, or by finger. The risk factors or predisposing factors to corneal abrasions include corneal exposure, either by having dry eyes, or facial palsy, in which the patient is unable to blink, contact lenses, diabetes, or a previous shingle exposure of the eye, a shingles infection affecting the eye. The signs and symptoms of corneal abrasion is predominantly pain, which can often be described as stabbing pain, and a unilateral red eye. The pain is usually sudden onset, and although it's usually +++, it can range from a mild foreign body sensation to that severe stabbing pain. And often the pain is disproportionate to the objective findings on examination. If the patient doesn't present with pain and it does appear to be a corneal abrasion, or what you think is a corneal abrasion, then you should consider neurotrophic keratitis. The course of the condition is essentially the patient will have a corneal abrasion, go to bed without any symptoms, and wake up the next day with that sudden onset pain, photophobia, and reduced visual acuity. The condition itself will usually clear within 24 to 48 hours, or 12 to 24 if it's a recurrent corneal abrasion. The main complications that you need to look out for are keratitis. The management plan for corneal abrasions are topical antibiotics, so Chlorseq, which you can get over the counter at the pharmacy, daily review until it's healed, and do make sure that there is a low threshold to refer. So if you are concerned of the complication being keratitis, if you are concerned that there are keratitic features, refer to an ophthalmologist. Oral analgesia, ocular lubricants for symptomatic relief, and don't patch the eye. So older management strategies may include an eye patch, but there is strong evidence to suggest that eye patches delay healing within 24 hours. So the main things to take away about the corneal ulcer is firstly the definition and the signs and symptoms in comparison to a corneal abrasion. So corneal ulcers are erosions of the eye through to the Bowman's layer, usually associated with inflammation or infection, and this develops over days. Risk factors include much of the same as corneal abrasions, and additionally ectropions, entropion, trauma surgery, autoimmune disease, specifically the Murren's ulcer. The main signs and symptoms are your unilateral red eye, photophobia, reduced visual acuity, and progressive eye pain over 1 to 3 days. The main complication that you need to look out for with corneal ulcers is the loss of vision. So the condition itself is potentially sight-threatening, which is why there is a low threshold to refer to an ophthalmologist. Investigations you'd want to consider are your slit lamp, which is not always possible in the GP land, so you may or may not opt for a fluorescein stain use the ophthalmoscope to see if there is a positive Seidels test. But corneal infiltrates will definitely be only observed using a slit lamp. You may or may not want to consider corneal scraping in the GP setting, as this could be done in the ophthalmologist, but you can consider it to determine the resistance and sensitivity profiles for antibiotic use. Regarding management, so urgent ophthalmology referral is important and it's your first step. However, you also want to make sure that you don't use topical anesthetics because it slows healing. And contact lens wearers should always assume that this is a microbial or bacterial keratitis until proven otherwise. The buzzword for contact lens wearers or the bacteria is Pseudomonas. So there are many causes of keratitis, with the focus being on viral and bacterial for our lecture and for your exams. So looking at bacterial keratitis, there are two main ones, which is marginal and microbial. Marginal keratitis is, typically speaking, not an infection, but rather an inflammatory response of the peripheral cornea to bacterial exotoxins, specifically the staphylococcal species or genus. It's common and can be recurrent if the underlying blepharitis is not treated. However, for microbial keratitis, the main things that you should be keeping in mind are the signs and symptoms of photophobia, pain, lid edema, and reduced visual acuity, and this is usually unilateral. The history is that of a 1 to 3 day history of red eye, often leading to corneal opacification due to corneal infiltrates, and on fluorescein stain, there will be an epithelial defect. The investigations typically use a slit lamp to observe the anterior eye, and so you can see in Hypertension fluorescent cells, but it's important to keep in mind that these signs or these findings are not specific to keratitis. The main complication of microbial keratitis is a rapid loss of vision, but you can also consider there are other complications include corneal perforation or endophthalmitis. Very sorry for the butchered pronunciation. But your management plan is an acute ophthalmology assessment. So within 1 to 2 days, you'll want the patient to have seen an ophthalmologist. If you do suspect that this is a bacterial keratitis, in the GP land, it's appropriate to perform a corneal MCS or corneal scrapings, hopefully before antibiotics have started. In the meantime, the patient is not allowed to drive and they should not be wearing contact lenses, and simple analgesia is fine for pain relief, and dark glasses can be worn just to reduce the strain on the eye. So keratitis is the most common ocular manifestation of herpes simplex virus. However, HSV infection can also manifest as blepharoconjunctivitis, anterior uveitis, or retinitis. Herpes simplex keratitis is classified depending on the layer of the cornea affected, including epithelial, stromal, and endothelial. And these will have different signs. The most common form is epithelial keratitis and is the main focus of your exam. It accounts for 50 to 80% of the cases. So the buzzword for you is dendritic ulcer on fluorescein stain. If you see the word dendritic ulcer or an image of a dendritic ulcer, just know that it is herpes simplex keratitis. Essentially what occurs is that there is a reactivation of a latent virus, usually in adulthood, in which the virus then travels down the trigeminal nerve, enters the cornea, and replicates in the epithelium to lead to ulceration. The management plan is typically well managed in a GP setting, in which the first line is topical acyclovir 5 times a day for 14 days. However, do bear in mind that there is a low threshold for referral, but especially with a dendritic ulcer or a child with vesicles and a red eye, or photophobia or an abnormal red reflex, or a non-healing ulcer. So those are the issues, or those are the signs and symptoms you should consider for a low threshold to refer to an ophthalmologist. Additionally, you should also refer if they have a significantly reduced vision or visible corneal opacity. Following this, you should review within 48 hours and ask the patient to return if signs and symptoms worsen before seeing a specialist. So with herpes zoster ophthalmicus, this is a clinical diagnosis, and it's often also known as ophthalmic shingles. It's caused by a localized reactivation of the varicella zoster virus in the ophthalmic division of the trigeminal nerve, and the most common sites of ocular involvement include conjunctivitis, followed by keratitis and uveitis. The main signs and symptoms that you really want to remember are the dermatomal or the distribution in the V1 segment, particularly eye scalp pain in that area. Essentially, what you'll see is an acute vesicular dermatomal rash in the V1 area, which is unilateral and does not cross the midline. Additionally, if you do have nasociliary involvement, this is noted as the Hutchinson sign, and it increases the risk of ocular involvement. So an image of the Hutchinson sign is depicted here in this image. The complication of ophthalmic shingles is iritis and keratitis, and it occurs usually 10 to 14 days after the rash onset, increasing the risk of post-hepatic neuralgia. So this condition does require an ophthal referral within 1 to 2 days. However, with a big focus on preventative medicine in GP, you should offer patients who are 65 and over, First Nations 50 and over, or immunocompromised 18 and over, the Shingrix vaccine, which is a 2-dose vaccine. Otherwise, advise your patients supportive management, which includes rest, fluids, analgesia as necessary. Medication-wise, it's typically oral valacyclovir or famciclovir within 72 hours of the rash for 7 to 10 days. So anterior uveitis encompasses the inflammation of the iris or iritis, or iridociclitis, I believe that's how you pronounce it, could be very wrong, which is the most common form of anterior uveitis and involves the inflammation of the iris and the anterior part of the ciliary body. The most important thing to remember is that it's associated with systemic disease, specifically your HLA-B27s, which you would have learnt in 3B, and this includes ankylosing spondylitis, psoriasis, IBD, and reactive arthritis. Importantly to remember, it's not associated with rheumatoid arthritis. Regarding the presenting complaint, some things to consider are the onset, so whether it's sudden or insidious, and the recurrence, so if there's been repeated episodes of uveitis separated by periods of inactivity without treatment, typically within 3 or more months of duration, that's considered recurrence. The onset usually is sudden at first episode, and then it becomes more gradual in the subsequent episodes. Typically, it's unilateral. However, if it affects both eyes, it's most likely associated with systemic disease and more likely to become a chronic issue. The pain in which patients experience is typically described as a dull ache, and it's exacerbated or induced by pupillary constriction, either direct, near, or concentral. Patients can also complain of photophobia, decreased vision, and waterier eyes. If there is a history of ocular surgery, you should really consider endophthalmitis. Oh my gosh, too many words. So consider that, which we'll discuss later as well. If on examination you were to look at the patient, typically for patients with anterior uveitis, you might notice a myotic pupil or a irregularly shaped pupil that has a slowed reaction to light or potentially even a painful reaction to light. On the slit lamp, you might be able to notice cells of flare in the anterior chamber, keratic precipitates, or hypopion. It's also dependent as well, so whether or not you'll see these in the GP setting, depending on whether or not there is a slit lamp. So the main aims of ocular therapy are to resolve the inflammation, relieve symptoms, return to normal vision, and to prevent ocular scarring. Although the course of an acute uveitis attack is generally 2 to 6 weeks, referral to an ophthalmologist within 24 hours is essential to an optimum outcome. Corticosteroid drops such as prednisolone are the preferred initial therapy, and it's important to monitor and carefully screen the patient during the time that they're taking this therapy for intraocular pressure, as the side effects of the topical corticosteroids is that it can raise intraocular pressure and it can lead to severe loss of vision if it's not appropriately monitored. Additionally, long-acting cycloplegics or mydriatics, such as atropine, can work to relieve the pain and reduce the possibility of adhesions. If inflammation does persist, periocular or oral steroids may be required. However, this is based on an ophthalmologist's review. Typically, the treatment is tapered over 6 weeks despite symptomatic and clinical quiescence to avoid bounce-back inflammation. During this period of time, the patient is under close review, and you may also consider in a GP setting to work up any systemic diseases. These workups would generally include an FBE, ESR, CRP, syphilis serology. In a child, you may consider ANA, UEC, and urinalysis for glomerulonephritis. If it's recurrent or there's a hypopion, you could consider screening for HLA-B27s. And if it's a granulomatous iris or iritis, consider a chest x-ray. But these would only typically be worked up if there are signs of systemic diseases. So whether it's a recurring iritis or anterior uveitis, if it's severe, bilateral, or if there are systemic symptoms. So during your history, it's important to screen for systemic symptoms related to the associated conditions. So endophthalmitis, I'm pretty sure that's how you pronounce it because I just Googled it, is the infection of your aqueous humor plus or minus the vitreous humor. The most important takeaway buzzword for you in this case is surgery or post-op. Essentially, the presenting complaint is that it is typically an acute sudden onset of a painful unilateral red eye with associated vision loss, with a recent history of intraocular surgery or penetrating eye injury. The management for this is an urgent ophthal review with intravitreal injections, for example, anti-VEGF. This is the mainstay treatment and it's ophthal initiated and not GP initiated. Most of the management plans for all of these eye conditions are ophthalmologist initiated. So you just need to be careful in your examinations as to what you are limited to in the GP setting. If there is likely to be a delay in ophthal review, you can consider systemic antibiotics, and the vitrectomy and intraocular or topical antibiotics is the definitive management plan for endophthalmitis. In this case, you may also consider systemic antibiotics depending on how severe the condition is. Moving on to orbital cellulitis and preseptal cellulitis. Orbital cellulitis is an emergency with serious complications including intracranial infections resulting in brain abscess formation, vision loss, and cavernous sinus thrombosis. In suspected cases of orbital cellulitis in the GP setting, you really should be referring the child or the patient to the hospital, so the ED department, for urgent imaging and surgical review. Pre-orbital cellulitis in a well child can often be treated with oral antibiotics if follow-up is probably confirmed or you are quite confident that they will present back to the GP clinic. The periorbital or preseptal and orbital cellulitis are distinct clinical diseases, but they do have overlapping clinical features. The main things to consider in orbital cellulitis is that the infection is posterior to the orbital septum, whereas in preseptal cellulitis, the infection is anterior to the orbital septum. The main causes of orbital cellulitis is sinusitis, but also include trauma, anaerobic bacteria or fungal infection, particularly in immunocompromised patients and patients with diabetes. Children under 4 are also at risk of Hib infections and therefore orbital cellulitis. The signs and symptoms of orbital cellulitis, the main things to consider are optic neuritic features. So these include painful and restricted eye movements, abnormal vision, and a relative afferent pupillary defect. As I mentioned before, the management plan for orbital cellulitis is an urgent referral to ED to allow IV antibiotics and then switch to oral if they are clinically stable. During this process, you would also want to send off bloods, which primarily you want to do a blood MCS, as well as a CT scan of the orbits and sinuses. The IV therapy includes Fluclox and ceftriaxone or cefotaxime by itself, and the oral antibiotic is Augmentin. With preseptal cellulitis, the main causes or contributing causes may be insect bites or a contiguous infection. The differentiating factor with these signs and symptoms is that in children with preseptal cellulitis, they have normal eye movements, visual acuity, and tend to be systemically well. However, based on the severity of preseptal cellulitis, these children may also require hospitalization, so particularly for moderate to severe cases. However, in mild cases of preseptal cellulitis, treatment with oral antibiotics and a review within 48 hours is enough. However, if there's no improvement with the course of oral antibiotics during this period of time, you would want to hospitalize them and send them to the ED so that they can receive IV therapy. This is a nice image off of AMBOS showing you where the infection occurs and how the site of infection essentially causes the symptoms. So with scleritis and episcleritis, the main thing to remember is that it is also associated with systemic disorders, including the list that I've got in there in the table. They both have different types, anterior and posterior for scleritis and simple and nodular for episcleritis. Whether or not you need to know these, I don't think you do for your exams, but the information is just here for knowledge or for your own interest. Regarding the clinical features, they do have some overlapping features, particularly it's a sudden onset painful red eye, described as a mild ache or a burning sensation. In episcleritis, there is no pain with movement, and typically the eyes are either watery and it's often recurrent. For scleritis, it's much of the same, however, there is more pain, which is hard to kind of differentiate as pain is subjective. However, there's also pain associated with eye movements, decreased visual acuity, or photophobia. Regarding the signs, in scleritis, we tend to see a bluish scleral hue if the sclera is thinning, but mostly the diagnosis for both of these conditions is based on clinical judgment. However, if there is signs of systemic disease, then you may want to work the patient up. Well, we tend to work the patient up to determine what the underlying systemic disease is, and we have bedside, bloods, and imaging investigations that can be performed. The management for episcleritis includes supportive therapies such as using cooled artificial tears for 1 to 2 weeks for symptomatic relief, as well as cold compresses. Typically, the episcleritis is self-resolving and will do so in around 7 to 10 days. In this time, you'd want to reassure the patient that episcleritis tends not to progress to any serious complications. However, in scleritis, typically this warrants an immediate opthal referral to screen for systemic diseases as well. The management for this will include systemic anti-inflammatories at high doses as well as immunosuppressive therapies. Conjunctivitis is one of the weird ones where it can be painful or can be painless, but essentially the general inspection of the eye in a patient with conjunctivitis is that they have a hyperemic conjunctiva with limbal sparing. The sensation in which they describe the eye can be gritty and itchy, plus or minus pain, and there is typically, most commonly, no visual loss and no photophobia. The main thing with viral conjunctivitis is the history of sick contacts or upper respiratory tract infections. The main thing to remember for this is that in viral conjunctivitis, the discharge itself is clear and the course is self-limiting, but it is highly contagious within the first 2 weeks. The management in this case is supportive, so you can use cold compresses, tear supplements, and to reduce the spread, it's really important to emphasize the importance of good hand hygiene and to wash any towels or shared towels and clothes separately as to not spread the virus. So with bacterial conjunctivitis, I have included the common bacteria involved in bacterial conjunctivitis, as well as the rare ones, gonorrhea and chlamydia, which are important for the sake of your exams to remember. So typically, like with viral conjunctivitis, it usually begins as a unilateral red eye before progressing to a bilateral red eye as the infection spreads. The discharge in this case is purulent and can cause that crusty sensation of your eyelids, but it resolves faster around in 7 days. The management is supportive. Similarly, reduce the spread of virus by performing good hand hygiene and washing the towels and clothes separately, but also includes Chlorsic for around 1 week. With gonorrhea and chlamydia, the complications of that are important to remember. So it can cause a corneal ulceration, visual loss, and the investigations would be as per kind of like your SDI protocols, but you would want to do a swab, PCR, and MCS. And the management plan is intramuscular IV ceftriaxone and zithromycin, depending on severity. Conjunctival cobblestoning, which you can see in the image on the right, is quite buzzy for chlamydia or chlamydial infection. Please note that trachomatous scarring can result in corneal opacity, so try not to get this confused with cataracts. And finally, with allergic conjunctivitis, this tends to be painless. The patient usually has a history of atopy and they do present with glassy, itchy, and watery eyes, typically with associated swelling of the eyelids due to that allergic reaction. The management in this case would be topical oral antihistamines. Moving along our differential list for painless red eye, firstly we have subconjunctival hemorrhage, which is caused by the rupture of conjunctival or episcleral blood vessels, causing bleeding into the subconjunctival space. The main causes are spontaneous or traumatic. Spontaneous causes include idiopathic, which is the most common, Valsalva maneuvers, including coughing, lifting, straining, vomiting, producing increases in your central venous pressure, systemic vascular diseases such as hypertension and diabetes, and medication-induced, for example, anticoagulants and NSAIDs. Traumatic causes include injury, which may be isolated or associated with a ruptured globe or retrobulbar hemorrhage, eye rubbing, ocular injury, as well as contact lens handling injury. The history is important and you really should be screening for the causes of subconjunctival hemorrhage. Other causes of Valsalva or contributing factors to Valsalva include weightlifting, and so you can screen for all of that. But essentially, the management is really to reassure the patient because it is self-limiting and it usually clears over 1 to 2 weeks depending on the size and whether or not the patient is taking anticoagulants. If the patient is on warfarin, it's important to check the INR, and if it was a traumatic cause, you should manage it as per a blunt trauma injury. Finally, you would want to refer the patient to an ophthalmologist if the subconjunctival hemorrhage worsens or if pain develops. So a pterygium is a wing-shaped benign fibrovascular growth, most commonly occurring from the lateral side and extending inwards to affect the cornea. It's mostly bilateral and often asymmetrical. The main risk factors is sun exposure, and so the management plan for these patients would include UV protection, using sunglasses, and a wide brim hat. Ocular lubricants can be used for symptomatic relief, and if the pterygium does end up involving the cornea, refer these patients to ophthalmology because corneal involvement can result in loss of vision. There is a similar condition which looks like a pterygium, but it's called a pinguecula. I believe that's how you pronounce it. But essentially, there will not be any corneal involvement. The growth itself will be a yellowy kind of appearance. And it's important to remember that this does not develop into a pterygium, so they're completely separate conditions. So blepharitis is the chronic inflammation of the eyelid margins associated with seborrheic dermatitis, staph aureus, and dry eyes. It's usually symmetrical and bilateral, and there are 2 main types, anterior and posterior blepharitis. Posterior blepharitis is associated with meibomian gland dysfunction, which in itself is associated with rosacea and chalazia. Anterior blepharitis is associated with seborrheic dermatitis and staph aureus. The symptoms of both anterior and posterior blepharitis is quite similar, and so differentiating between the two can be quite difficult. But these symptoms include ocular discomfort, soreness, tearing, burning, and itching of the eyes, or eyelids specifically. Blepharitis in itself can also be asymptomatic. However, the management plan for both of these is the same and involves eyelid hygiene. This includes daily warm compresses, gentle scrubbing of the lashes with cotton wool, and baby shampoo. In these patients, you should advise them to avoid makeup and contact lenses. And for the dry eyes, you can advise to give Cystane or eye lubricants for symptomatic relief. There are severe cases of blepharitis, but it's not too relevant for your exams, but I've included them here on your slide for you to have a look at in your own time. Moving forward, these conditions are mainly important for you to be aware of, so I won't go through every single point, but I'll cover the main things you should be aware of. So with an entropion, which is when the eyelid turns inward, this can and may irritate or ulcerate the cornea, and so it's important to check if there's a defect. If there is a corneal defect, tape away the eyelid from the cornea and manage as per corneal foreign body. With an ectropion, this is the E version of the lower eyelid, and the management plan is quite simple. You would lubricate the eye and send for a non-urgent referral to the ophthalmologist. With a trichiasis, which is when there is a normal lid position, but the eyelash growth is misdirected due to, most commonly, chlamydia infection. This is most common in the remote Aboriginal and Torres Strait Islander communities and may lead to vision loss and blindness. The management plan for this is eyelash epilation, a non-urgent ophthal referral, lid hygiene, and antibiotics if it's caused by a trachoma. So for chalazions and hordeolums, they're actually quite difficult to tell apart, especially based on a spot diagnosis. The reason I think that you won't be given a spot diagnosis question in the exam is purely because I tried making a somewhat spot diagnosy type of question for our revision packs and was told to change it. And so that's why I don't believe you'll get something like that. But if you do, really sorry, but hopefully you won't. Essentially, a chalazion is a chronic lipogranulomatous lesion affecting the upper or lower eyelid, and it's caused by the blockage of meibomian glands with retention and stagnation of secretions. It's most commonly associated with blepharitis, and as you can imagine, more likely posterior blepharitis, as that's the one that's associated with the meibomian gland dysfunction. The symptoms of this include a painless hard lump above usually the upper eyelashes, and the course itself is self-limiting. Management is conservative, which includes warm compresses 3 to 4 times a day, gentle massage, and hand washing. You may want to consider antibiotics if there is periorbital cellulitis, or an incision and drainage if the chalazion is persistent. With hordeolums, the external one, which is most commonly known as a stye, is usually due to a Staph aureus infection of the gland of Zeiss or mole. The internal hordeolum is a meibomian abscess and is due to the infection of the meibomian glands. This presents as a painful red lump at the hair follicles and points outwards. The course itself is that it may be self-limiting and may drain spontaneously. Similarly, the management plan is conservative but may include eyelash epilation and removal, as well as antibiotics, incision and drainage if it's persistent, like chalazions. We'll now move on to our new differential lists, which is sudden and gradual loss of vision. Regarding retinal artery occlusions, there are 2 main types in which you should be aware of: central or branch artery occlusions, in which by definition they are occlusions that do not resolve in 2 to 3 hours. Regardless, a symptomatic retinal artery occlusion is an ophthalmic emergency. The causes of the obstruction to the retinal blood flow may be due to an embolus causing occlusion or thrombus formation, vasculitis such as giant cell arteritis causing retinal vasculature inflammation, traumatic vessel wall damage, or spasms. The lack of oxygen delivery to the retina during the blockage often results in severe vision loss in the area of ischemic retina. Patients often have concurrent silent ischemic strokes at the same time, and so typically the central retinal artery occlusions is what we refer to as an eye stroke. The risk factors as such are similar, or if not the same, to stroke risk factors. So we have your hypertension, diabetes, dyslipidemia, and smoking, among others. Signs and symptoms are that there is a sudden painless loss of vision in the affected eye. However, with branch retinal artery occlusions, the vision loss is typically partial, whereas the entire visual field is lost in central retinal artery occlusions. More commonly in CRAO, we do have a relative afferent pupillary defect. On fundoscopic examination, you'll notice a cherry red spot in these conditions, and so you can see that here in the image below. If you see that, or if you hear or read the word cherry red spot, you can be quite confident to assume that they're talking about a retinal artery occlusion. The management by this would be, firstly, in the GP setting, to be immediately refer them to an ophthalmologist or an ED department with an ophthalmology department. Keep the patient nil by mouth, and to restore the blood flow, there are multiple techniques in which you can do. These include ocular massage, the reduction of intraocular pressure, intraarterial fibrinolitics, which is anti-TPA, IV-TPA, increase blood oxygen content, and to dilate retinal arteries with nitrates. So it's very kind of strokey, but that's essentially the idea behind it. Similarly to retinal artery occlusions, retinal vein occlusion also has the central and branch retinal vein occlusion. The most common etiological factor is vein wall compression by adjacent atherosclerotic retinal arteries. Other possible causes are diseases of the vein wall, such as vasculitis or blood constituent abnormalities. RVO occurs following a complete or partial obstruction in the central retinal vein or one of its branches. Predisposing factors include old age, in which it's more common or most common in the 6th to 7th decade, and uncommon in those under 40. The risk factors are similar to or the same to those in AIO and stroke, and these include hypertension, diabetes, dyslipidemia, and smoking. Other risk factors actually include glaucoma, a history of MI or stroke, blood coagulation disorders, and systemic vascular inflammatory disorders as well. Signs and symptoms is that it's a sudden painless loss of vision in the affected eye. However, in comparison to RAO, the loss of vision can be more gradual. In BRVO, the visual loss is in a single quadrant, whereas in CRVO, similarly to CRAO, the entire vision is lost. Similarly, there is also a relative afferent pupillary defect in CRVO. Fundoscopic examination will show a blood and thunder appearance, which you can see in the image on your right, in which the hemorrhages of the fundus kind of look like a blood and thunder appearance, or like a stormy appearance. The management for this would be an urgent ophthal referral, in which laser photocoagulation and anti-VEGFs will be initiated. Retinal detachment is one of the main ophthal conditions you should take away. The buzzword for this is if a patient describes a curtain covering their visual field, main word being curtain. The definition is the detachment of neurosensory retina from the retinal pigment epithelium. There are three main types, categorized under two main categories, being regmatogenous and non-regmatogenous. Regmatogenous retinal detachment happens in which there is a tear in the retina that allows the vitreous humor to accumulate beneath the retina. In doing so, the fluid can then push the two layers apart from each other, causing detachment. The risk factors are posterior vitreous detachment, intraocular surgery, trauma, myopia, increased age, and family history. Non-regmatogenous retinal detachment includes tractional and exudative retinal detachment. In tractional retinal detachment, what happens is that there is a progressive fibrovascular proliferation and contraction, and which in doing so splits the vitreous humor and the retina. Causes the detachment. The risk factors are retinopathy of prematurity, in which there is an abnormal growth of blood vessels over the retina in premature babies, proliferative diabetic retinopathy, sickle cell retinopathy, trauma, and inflammatory effusions. In exudative retinal detachment, there is an accumulation of fluid, essentially beneath the retina, in the absence of retinal tears. And what happens is that that buildup of fluid results in detachment. The risk factors are primary ocular tumors, mets to the eye, infections such as syphilis, sarcoidosis, and hypertension. The clinical features are relative afferent pupillary defects, which is an examination finding in patients who have an asymmetric pupillary reaction to light when it's shined back and forth between the two eyes. Additionally, you'll have prodromal features such as floaters and flashes. And like I mentioned before, the buzzword here is a curtain descending over your visual field. The investigations in which you may perform are fundoscopic, in which will reveal a grey and wrinkled area. So you can see in the image on the right at top, if I get my laser, this part here is essentially the retinal detachment. So essentially where it's more pale and it's quite well circumscribed is the retinal detachment area. An ocular ultrasound will reveal thick cords that move with the eye movements, but this is probably most likely irrelevant to your GP clinic, as these ocular ultrasounds won't be present or available in a GP setting. The management for retinal detachment is an ophthal referral, an urgent one, in which the definitive management really depends on the underlying cause, but options include photocoagulation, chiropexy, internal tamponade, and external tamponade. The complications of retinal detachment include permanent blindness, proliferative vitreous retinopathy, which involves the growth of membranes within the eye, which can contract and cause the retina to detach again. It's characterized by the formation of fibrous or scar-like tissue on the surface of the retina and within the vitreous cavity. Toxic uveitis and retinal detachment in the other eye. So these are just some images summarizing the different types of retinal detachment that you can have a read of in your own time, but they have a few more details that you're not necessarily going to need to know for your exam. So posterior vitreous detachment is a very common and usually benign condition. It essentially is the detachment of the posterior vitreous from the retina. Risk factors include increasing age, myopia, ocular trauma, and surgery. Signs and symptoms include flashes and floaters, in which the patients will describe to you. The management plan is really reassurance and education. In most cases, like I said before, it will self-resolve over time, so it's quite important to emphasize to the patients. However, in saying that, you would still want to monitor for possible complications such as vitreous hemorrhages, retinal hemorrhage, retinal tears, and retinal detachment. Vitreous hemorrhages are the leakage of blood into the vitreous, and it's once again an urgent ophthal condition that needs to be referred accordingly. The causes of vitreous hemorrhages include proliferative diabetic retinopathy, PVD, retinal tear and detachments, and ocular trauma. The signs and symptoms are very similar to PVD and retinal detachment. However, there is no relative afferent pupillary defect. On examination findings, the fundoscopic examination typically assesses the extent of the hemorrhage. However, the following, so ultrasound, angiography, and OCT, are more relevant in the setting of an optometrist or an ophthalmologist. And so in order for these to be assessed, you would refer accordingly. An ultrasound is useful if the hemorrhage obscures the view of the retina, and the fluorescein angiography identifies the area of leakage or neovascularization. And the OCT allows detailed images of the retina to identify underlying pathology. The management for vitreous hemorrhage is an urgent ophthal referral, in which medical management would include anti-VEGF injections, while the surgical management includes a vitrectomy and photocoagulation or chiropexy to treat the underlying cause. Anterior ischemic optic neuropathy, or AION, is the ischemic damage to the optic nerve. There are two main types: non-arteritic AION, which is the most common type and is associated with vascular risk factors and older age. Secondly, there's arteritic AION, which is associated with inflammation of the artery supplying the optic nerve, often due to giant cell arteritis. The signs and symptoms of AION include the sudden painless loss of vision in the affected eye, relevant afferent pupillary defect, and if it's caused by GCA, then you'll have features of giant cell arteritis such as scalp, temple, neck, and jaw pain. Predominantly, it would be scalp and temple pain. The neck and jaw pain and shoulder pain or muscle aches are typically common with polymyalgia rheumatica. Other symptoms include general fatigue, weight loss, and fever. So with GCA, the common stem or scenario in which you'll see is a little old lady having unilateral pain when she brushes her hair. For your examinations, in the GP setting, really the fundoscopy is the main one, as well as relevant bloods as well. But for the fundoscopic examination, you look at the optic disc for edema or pallor. Bloods include FBE, CRP, and ESR, and a biopsy for the superficial temporal artery for GCA. OCT is done in an ophthal setting in which you would assess for the optic disc edema and retinal nerve fiber layer thickness. It can also be done by an optometrist. The management depends on the type of AION. So for non-arteritic AION, it's supportive care and management of the underlying risk factors. In arteritic AION, this requires an urgent ophthal referral for urgent treatment with high-dose corticosteroids. So finally, we have amaurosis fugax and optic neuritis. Amaurosis fugax is also referred to as retinal TIA and is often associated with the ipsilateral carotid artery stenosis or emboli from the heart. As the condition increases the risk of CRAO and stroke, it should be investigated and managed immediately. The risk factors are the same for CRAO, and the signs and symptoms are a transient vision loss, so seconds to minutes, and a curtain passing across the eye. But this is more so of a buzzword for retinal detachment than it is for amaurosis fugax. The management would be immediate investigations and management as per a high-risk stroke protocol, which may include ECG, bloods, carotid Doppler, and echocardiogram. Ultrasound echo, not an echocardiogram. The bloods in which I have included here, so things like fasting lipids and HbA1c, are less likely to be done in an acute setting, and this is more so of a follow-up in the GP setting. With optic neuritis, this is the inflammation of the optic nerve, most commonly occurring in women aged 20 to 40 years old, and is more often than not the first presentation of multiple sclerosis. And so your main goal here in screening or in talking to patients with optic neuritis is to screen for multiple sclerosis. Signs and symptoms of optic neuritis include painful eye movements, diplopia, relative afferent pupillary defects, enlarged blind spots on visual field, the loss of red, the color red in your vision, and the course of this typically occurs over days to weeks. On fundoscopic examination, initially the optic disc will appear normal. However, over the incoming weeks, the optic disc will result in a more pale color and it may become more edematous. With the management, you'd refer to a specialist if this is a new presentation. And like I mentioned before, investigate and manage as for MS. The loss of vision associated with age-related macular degeneration can either be sudden or gradual. ARMD is the most common cause of irreversible vision loss in the developed world, and it's associated with the presence of drusen or lipid deposits without visual loss early in the disease. ARMD often slowly progresses over years to retinal atrophy and central retinal degeneration with associated loss of central vision. Risk factors for ARMD include old age, family history, smoking, and diet, specifically a low dietary intake of antioxidants. Research has found that a Mediterranean diet that includes fruits, veggies, and fish is associated with a lower risk of ARMD. There are two main types of ARMD. There's dry, which is the most common type, in which there are bilateral and asymmetrical drusen deposits under the retinal pigment. This deposition of drusen can result in ischemia of the retinal pigment epithelium and photoreceptors. As a result of the loss of photoreceptors, this can actually also lead to wet ARMD, but it's often asymptomatic in early disease for dry ARMD. In wet ARMD, the drusen deposits are unilateral, and there is an associated growth of abnormal vessels under the retina that leak, bleed, and progress to an untreatable fibrotic scar, resulting in a significant reduction in visual acuity. On history, the main presenting complaint is the reduction of central vision. With wet ARMD, this reduction or the loss of central vision is typically more acute and rapid than dry, but the onset can also be insidious, so weeks to months. Aggravating factors include nighttime reading and near vision, while alleviating factors include using a magnifying glass, good and natural lighting, and without refractory correction. Investigations include using an ophthalmoscope to observe the fundus, in which you'll be able to see a pale atrophic macula, yellow drusen under the macula, plus or minus neovascularization, and plus or minus subretinal hemorrhages. AMSA grids, like I mentioned before, is more of a screening tool for patients to have at home. But what you'll see in wet ARMD is metamorphopsia, which you'll see on the next slide, while in dry ARMD, rather than seeing metamorphopsia, which is more common, I guess, in wet, the lines will still be straight but faded. Regarding the management, it's an urgent ophthal referral if there is a sudden or rapidly progressing visual loss. Risk factors would be managed via SNAP-W, and this is your typical GP type of management plan. With wet AIMD, the first line is anti-VEGF injections, while in dry AIMD, you'll want to optimize the vision by using visual aids, continual monitoring, doing annual examinations by the optometrist, and the AMSLA grids as a self-screening tool. There is no treatment for late-stage dry AIMD at this point. However, treatment with anti-VEGF injections for wet AIMD should be initiated as soon as the diagnosis of wet AIMD is made, as the delay in anti-VEGF injections or therapy after the first symptoms of wet AIMD has been associated with poorer vision outcomes. And so, referring to the AMSLA grid that I mentioned previously, essentially this is what happens in metamorphopsia with the AMSLA grid. There's the distortion of these straight lines, resulting in this somewhat like curvy appearance. Cataracts are the opacification of the lens and result in the gradual loss of vision. The main risk factors or causes of cataracts are old age, infective, and drug-induced, specifically steroids. The rosette, snowflake, and green sunflower descriptions that I have there are basically descriptive factors that describe how the cataract appears. So if you were to search that up, it actually does look like on Google Images, you can see that the cataracts do actually have somewhat of a snowflake or rosette appearance. The main signs and symptoms to note is that in cataracts or patients with cataracts, the eyesight is gradually worsening and the vision is either blurring or smudgy despite recent changes in glasses. The visual acuity itself on examination using a pinhole also doesn't improve, and that's important to note. The course of cataracts is that early management will not change prognosis except for in congenital cataracts, which can cause lazy eye or misalignment. With the management plan, so typically if the visual acuity in the better eye is less than 6/12, you would advise for the patient to not drive and consider a Vision Australia assessment test. Conservative management for cataracts include an ophthalm referral for corrective glasses and to avoid smoking and sunlight overexposure, so risk factor management. The definitive treatment for cataracts is surgery, and when you would want to perform surgery or whether or not you would want to perform surgery isn't dependent on the surgeon, but rather it's by the informed patient, except in cases in which the cataract limits monitoring for retinal or optic nerve diseases. So in diabetic retinopathy, which occurs due to hypoglycemia or poorly controlled diabetes, in which the blood sugars cause damage to the blood vessels of the retina, the risk factors include poor control of your diabetes, a longer duration of the diagnosis, chronic kidney disease associated diabetes, hypertension, dyslipidemia, and smoking. There are two main types, non-proliferative and proliferative. In non-proliferative diabetic retinopathy, the signs and features include microaneurysms, dot blot hemorrhages, cotton wool spots, hard exudates, macular edema. Vision is usually unaffected unless it's advanced or the macula is involved. So the main things that you want to remember are what the cotton wool spots look like, what exudates look like, the microaneurysms, and the dot blot hemorrhages. So as you may or may not get a spot diagnosis for these. With proliferative diabetic retinopathy, the features of this include angiogenesis, vitreous hemorrhage, retinal detachment, and vision loss. It's important to note that diabetes is also a risk factor for cataracts and glaucoma as well. Investigations include fluorescein angiography and OCT. And for the course of diabetic retinopathy, most patients don't need treatment, but a reduction in the visual acuity may be irreversible. Management for diabetic retinopathy in GP land focuses primarily on prevention. So this includes monitoring of the diagnosis and regular optom reviews. Ask the patient in your history when the last time they visited the optometrist is, as most patients with diabetes should know that they do need to visit them regularly. Ophthal referral can be considered if there is maculopathy, lesions near or around the macula or the disc, moderate to severe non-proliferative changes and proliferative changes. These are typically made by the optometrist, as they will be the ones mainly reviewing the patient's eyes. And an urgent referral is required if acute visual signs and symptoms are present on established retinopathy. You'd also want to reduce the risk and slow the progression by controlling the blood glucose levels, monitoring blood pressure, lipids, and advising smoking cessation in patients who do smoke. Regarding proliferative diabetic retinopathy, these would be under consideration for anti-VEGF injections and laser photocoagulation, and this will be done by the ophthalmologist. So for hypertensive retinopathy, there are 4 grades ranging from 1 to 4 and varying in severity. I won't list them all out except mention maybe for grade 2, essentially what you'll see there is AV nipping. That's in the images that I've attached here. So AV nipping here. And it's essentially the compression of venules at the sites of atriovenous crossing. Otherwise, I didn't really prepare hypertensive retinopathy amongst other conditions for ophthal. Like I mentioned before, ophthal is one of the ones where as long as you are aware of the main conditions, you'll be okay. And the management will hardly ever ask you about the ophthal initiated management plans because it is a GP exam. But in this case, for hypertension, obviously the preventative things would be hypertension control, which can easily be done in the GP setting. This is a summary of the refractive disorders. So for myopia, hypermetropia, presbyopia, and astigmatism. In myopia, this is commonly referred to as short-sightedness, in which you can see close objects better than far away. Essentially what happens is individuals may have a longer eyeball, and as a result, there is too much focusing power, and the image focuses in front of the retina. This condition, or this refractive disorder, can increase the risk of retinal detachment and macular degeneration, and you would correct this by using diverging lenses or concave lenses. Hypermetropia is farsightedness, in which you can see far objects better than close objects. So there is usually a shorter eyeball, and as a result, there's too little focusing power, in which the image focuses behind the retina. This increases the risk of acute angle closure glaucoma, and it's corrected with converging lenses. Presbyopia is age-related, so those greater than 40, long-sightedness, as the lens is progressively unable to accommodate near objects. Similarly to hypermetropia, there is too little focusing power. Astigmatism is when the cornea shape is abnormal and not spherical. Essentially, the eye itself has an uneven curvature, causing irregular focusing, and so the image focuses on multiple points on the retina. And if you have astigmatism, what you'll realize is that when you're driving at night, there are these lines that kind of like shoot out at different angles from the lights. Other conditions to note, I didn't really study for these ones. I just assumed they wouldn't pop up on the exam, and they didn't. So there's that. Take it as you will. But we have retinitis pigmentosa, which is a hereditary degeneration of rods and cones. The buzz scenario is typically there is a young person with peripheral vision loss, in which the mum also has tunnel vision. That's your buzz. However, specifically, the onset is in childhood, in which the patient will present with nighttime blindness and a loss of peripheral vision. Fundoscopic examination will reveal arteriolar narrowing, perivascular pigmentation, and optic disc pallor. Neoplasia, essentially, there are a few neoplastic conditions to be aware of, but essentially what happens is that the neoplastic condition or the concern or the issue at hand will cause pressure and swelling, pushing on the optic nerve, optic chiasm, or the occipital cortex. The main conditions to note are uveal melanoma, and the presentation for the uveal melanoma affecting the iris is that there will be a distorted pupil shape, brown nodules on the iris, and blurred vision. Choroid or ciliary body melanoma is initially asymptomatic, but can result in exudative retinal detachment and blurred vision. And retinoblastoma we should all be quite aware of. The main thing for this is that there is an absent red eye reflex. Finally, the last differentials list is foreign body sensation. When it comes to foreign body and eye trauma, your history and examination are really important. On history, it's good to assess the pain and what the pain is associated with. Also assessing whether or not the patient may have an infection risk. For example, were they wearing contact lenses? Were there any exposure to gardening seeds or insects? And the timing of the incident, as you would want to figure out whether or not a rust ring could have formed if it was a metal that was in their eye. You'd also want to exclude a penetrating injury, and in doing so, you'd also figure out what the mechanism of the injury was. Assess whether or not the patient has a reduced vision, visual acuity or loss of vision, just based on asking them questions, because this can also be examined as well. And consider any irritation to the eye or any unusual eye symptoms or visual changes that they may experience. On examination, if you do suspect that there is a penetrating eye injury, do not examine, and you should refer emergently to opthal or to ED. Assess for visual acuity as per usual, and for the anterior eye exam, it's most well done using a slit lamp. However, in the GP setting, you're not going to have that available, because essentially what the slit lamp allows is the depth of the corneal foreign body to be noted. So on your exam, you want to really figure out what the location, size, and the depth of the foreign body is, particularly if it's in the central pupillary zone. Surrounding corneal opacity may indicate a rust ring, burn and infection, edema or scar tissue. Irregularities in the pupil shape may indicate a penetrating foreign body causing iris incarceration. And some of the special tests you want to perform are fluorescein staining for foreign body, abrasion, ulcer, or perforation. So with your management of foreign bodies and eye trauma, you would refer to an ophthalmologist if it's indicated. However, there are different removal methods which you can do in a GP setting or ED or an opthal setting. Firstly, with superficial foreign bodies, you can simply irrigate it, or you can use sterile cotton buds with local anesthetics to remove it, assuming there is no corneal reaction or involvement. If there is corneal involvement, or if the foreign body is quite deep in the eye, then you would consider using a 25 gauge needle bevel up, with the needle approaching the cornea horizontally. It's important that you do approach the eye horizontally, as there is a small risk of perforation. With rust removal, you may also use a burr or a needle with the burr oriented perpendicular. You want to be careful because this can result in a larger defect or scar. With the needle, it's more precise, but like I mentioned before, there is a small risk of corneal perforation. If it's a difficult to remove rust, you should apply topical chloramphenicol 4 times a day to assist with the removal 2 to 3 days after, but this will typically delay the removal process. With the patches, previous revision lectures say to use an eye patch. However, the current literature suggests that you should not use eye patches or eye pads. Eye pads should only be used if there is a large epithelial defect following the removal, in which a double eye pad may be used for 24 hours to reduce the discomfort. Pain management as per usual, and you'd want to refer the patient or review the patient in 24 hours, informing them and advising them to return primarily to the ED rather than to the GP if there is increased pain, photophobia, or visual impairment. When you don't, there are certain circumstances in which you yourself do not want to remove the foreign body. Firstly, if you don't feel confident in your abilities to remove it, refer to an opthal. If it's in child, or if the foreign body is central or appears deep, so there is a risk of scarring, this requires urgent referral. Commonly next year, if you do have any eye presenting complaints or foreign body complaints, in the ED department, a lot of the consultants will be quite comfortable to remove foreign bodies if it does affect the cornea. However, they will only give it a certain amount of tries, and essentially afterwards, if they still aren't able to remove it after 2 or 3 times, they will refer the patient to opthal. Chemical burns are an ophthal emergency and you want to irrigate prior to history and exam. This is really important. So essentially, there's acidic and alkali substances, in which alkali substances are more severe and penetrates deeper. Examples of alkali substances include lime, limestone, cement, concrete. Acidic examples include toilet cleaner, car battery fluid, pool cleaners. On history in exam, you want to figure out what the chemical was, what the ingredients were. If you don't know what they are, contact poisons information to inquire about the pH. Where is the burn? And if there are any burns elsewhere, for example, contact with the skin, face, neck, hands, or anywhere else. And you want to know what the quantity and force of exposure is. So splash versus high velocity, and the impact it has on the patient's visual field or visual acuity. With the associated symptoms, you'd want to inquire about inhalation injury, so your respiratory signs and symptoms, which include chest tightness, shortness of breath, and ventilation. So consider your oxygen sats. So you would do a general exam and vitals in this case. For your examination, examine the anterior eye to exclude any penetrating injuries. And your signs and symptoms for chemical burns are typically that there is a severe type of pain and a severe reaction to the burn, in which you'll note corneal opacity, blanched conjunctiva, and sclera. The management, like I mentioned before, is irrigate. Irrigate, 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 refer to the hospital on the same day. Irrigation can be done in the GP setting, and essentially you want to set the eye up properly, removing any contact lenses, test the pH. GP land, GP setting, they have pH litmus paper, so you can test the pH. You want to irrigate until the pH normalizes, which typically takes around 30 to 60 minutes, using typically what it is 1 liter of normal saline or Hartmann solution. Continue reviewing the pain level every 10 minutes and add another drop of local anesthetics, or add drops of local anesthetics as required. Following this, typically this is probably not done in the GP setting, it's probably done either in the hospital or ophthal. Do a full eye examination. So this includes lid eversion, examination of the cornea, examination of conjunctiva, and to see if there's any limbal ischemia. So thanks for listening, everyone. Hopefully you found this beneficial. Very sorry for the poor pronunciation of some of the words. Very shocking when it comes to pronunciations. I try not to pronounce words and I only do it in my head, but for the sake of the lecture, obviously have to. If there's anything that you need clarification on, or if you have any questions about things that I might have missed, feel free to message us on our Facebook page or email me directly. There'll be questions provided in the slides, but I won't be going through them just because it's quite awkward to be going through questions with no one in attendance.